My name's Ken Levy, and I will be presenting a meta-analysis that I've done with my colleagues, Bill Ellis and Christina Temis and Shabad Ratan-Khalsa, where we looked at the psychotherapy treatments for borderline personality disorder. And before beginning, I'd also just like to point out and thank Bill Ellison, one of the authors, because he did the statistical analyses. He's quite a meta-analyst and quite a data analyst. And you'll be seeing him in future years here presenting. Now, we've heard reference to a number of different psychotherapy treatment options for people with borderline personality disorder. And here you see just some of the treatments that have actually been tested in randomized controlled trials, some coming from a cognitive behavioral tradition, some coming from a psychodynamic tradition. And many of these treatments have been assessed in 2 or more randomized controlled trials, which is a criterion for being an empirically supported treatment from the American Psychological Association, Division 12. And there's actually a number of other treatments that have been tested in pre-post studies, like Joel mentioned his, but others too, that have actually very good data and probably warrant future research. The point I'm trying to make here is that there's a lot more out there than I think people often consider. And there's actually a rationale to be aware of all the different treatments and for us to be examining their effects. And through the meta-analysis, I hope to make that point. But one issue in general is that studies consistently show only about 50 to 60% of patients in treatment are actually improving. And that's a lot of patients who aren't actually improving. And maybe they're, like Joel said, there are people who won't necessarily get better in any treatment, but they also may be people who would get better in a different treatment, and even a treatment from a different orientation. And so I think it's important that we be aware of all that is out there and what the effects of these treatments might be. In addition, even those patients that do show effects in treatment, the 50 to 60% that do better, they're showing often clinically significant change. If you go from a 35 GAF to a 65 GAF, you've made clinically significant change, but you haven't made clinically sufficient change. None of us in this room would want to be functioning at a 65. And so a lot of the changes that you see, the reduction in hospitalizations and ER visits, et cetera, are really important changes, but they're not necessarily enough. And the meta-analysis, it was our hope, would actually help us understand what kind of factors were contributing to the outcome that we see in these various treatments. Now, if you look at the literature, it's quite complicated. There's a lot of variability in the various studies out there, and here are just some of the ways that these studies have varied in terms of dose and treatment setting, samples, outcome measures, et cetera. And there are other issues that actually affect the literature, such as researcher allegiance and publication biases. And how are we as researchers and clinicians to draw conclusions from this data to make both research decisions in terms of where we want to put our efforts at the most cogent questions, and how are clinicians in the community to make decisions about triaging patients to particular treatments. And so we thought a meta-analysis would be helpful in that regard for organizing the data, as well as looking at treatment moderators. And this was one of the main issues that we wanted to do in this meta-analysis, was actually look at treatment moderators. Now, this is a pyramid of evidence that has been articulated in the empirically supported psychotherapy literature. And you'll notice actually at the top of this pyramid is systematic reviews and meta-analyses. Often meta-analyses have been actually quite controversial in recent years. You heard Joel mention the lesson ring meta-analysis, which I think is one of the controversial ones, but there have been other instances too. But meta-analysis can be quite useful for summarizing data, and any individual study that's carried out can also distort practice, because we may put too much emphasis on that study. And I think we'll see when we look at the results of the meta-analysis that something like that has probably been going on now for many years. There have been 3 recent meta-analyses, actually a 4th one on dropout that I won't talk about, but the 3 main meta-analyses are the ones that were published by the Cochrane Report in 2009 by Binks et al. A year later, a meta-analysis on DBT that was consulted in clinical, which Bill and I actually were a reviewer on, and then the most recent Cochrane Report by Stoffers et al. Lieb that was recently published. And these with 3 meta-analyses, you may be saying, why another meta-analysis? But these meta-analyses were limited in particular ways that we wanted to actually address. The initial one, Cochrane Report meta-analysis, actually examined only 7 treatments, or 7 treatment studies, 6 of which were DBT, about 260 patients. And at the time, what the conclusion was that the confidence intervals were so large around the effect size that that the findings were unreliable. And they essentially said, well, it looks like BPD could be treated with psychotherapy, but all treatment should be considered experimental. A year later, 16 studies of DBT were meta-analyzed, and in this study, they found a moderate effect size for DBT when compared to treatment as usual, but buried in this article, even though Bill and I tried to get this out, was the fact that when DBT was compared to an active control, the effect size was 0.1. And so DBT clearly effective compared to a TAU, but in this study does not necessarily look like it's better than any of the other active controls that it was compared to. And then finally, the meta-analysis by Stoffers and colleagues. This was actually more of a series of sub-analyses that actually are hard to sort of summarize. But essentially their conclusion was that DBT is the most intensely studied of these treatments and therefore has the most evidence. MBT, TFP, schema-focused therapy, and STEPS are also treatments that have evidence and are promising. We wanted to take a very different approach to our meta-analysis. I'll say a little bit about that before I go to the critiques. We wanted to actually look at moderators, and in order to do that, we felt that we should actually include as many of the studies that have actually been completed. Most of these studies have inclusion and exclusion criteria and result in sort of subsets of studies that are available for the meta-analysis. And we wanted to be overly inclusive and actually look at design issues and patient variables and treatment variables as they might moderate the effect size. Meta-analysis, as I indicated before, is controversial. There's a number of critiques that are out there. The inclusion-exclusion critique is an important one because there's been a number of meta-analyses where people have published on the same issue within a year or two of each other and actually found very different conclusions. So Chris Christoph and Schwartzberg looked at dynamic psychotherapy for depression, found different conclusions. Tolan and Wampold looked at CBT, found very different conclusions. And Smits and Lessenring found different conclusions. And sometimes these arguments have actually gotten quite nasty. In reaction over the last few years, there's been recommendations about reporting guidelines and also assessing the quality of the meta-analysis. We, in our meta-analysis, use all 3 guidelines, and we adhere to every relevant guideline for our meta-analysis. We're hoping to not be critiqued on some of the same grounds that other people have been critiqued on. Okay, so turning to the method, we did extensive literature search, looked at conference abstracts, retrieved articles through reference sections, made appeals through listservs. Many of you may have received that. And we identified over 2,100 articles that were then combed through to determine whether they would meet eligibility. In terms of our eligibility or inclusion criteria, we stayed very close to issues of relevance and pragmatics. So in terms of relevance, we only looked at studies that were psychotherapy, because this is the question we were interested in. We also looked at specific treatments for BPD, treatments specifically for BPD and not associated diagnoses like depression. We also wanted BPD patients, not mixed diagnoses or individuals with, let's say, an associated problem like self-harm, but not necessarily knowing whether they had borderline personality disorder. And in terms of the pragmatic concerns, we had to be able to read the article, and it had to have understandable statistics that we could use in the meta-analysis. And you can see the number of articles excluded as a function of that. This is a flow chart that shows how we got to where we ended up with 73 articles or 73 studies for inclusion in the meta-analysis, which is quite a lot of studies. In fact, we had no idea that there were going to be that many psychotherapy studies of borderline personality disorder when we started this. So 73 studies, We looked at both between groups and within group effects. There were 32 between group studies, 32 studies that provided between group effects, over 1,700 subjects, 70 studies that we were able to get pre-post effect size estimates, again, over 1,700 individuals. I'm going to skip through this quickly. We used Hedges-G to look at between group effect sizes. It actually controls for some of the biases with small samples in Cohen's D. We used this robust covariance estimation, which was a new procedure that was actually quite useful in the moderator analyses. And we used Becker's modification of Hedges-G, which doesn't necessarily have a name associated with it for within group effect sizes. We looked at sample moderators, study level moderators, treatment moderators, design moderators, as well as the effects of raters on outcome and domain of outcome. And our coders were both graduate students and advanced undergraduates, graduate students with regard to moderators and study quality, which is something that we addressed. We used Downs and Black, which is a standard measure developed for rating studies in meta-analyses. I won't go too much into detail about that. There are a couple of others. In terms of our reliability of coding, you can see it's quite high. Interestingly, our ratings of the quality of studies was quite high too, and there was another study that actually had an overlap of 7 studies that were included in ours, and we looked at the relationship, the reliability between our ratings and their ratings. It was 0.91. Small sample, no one fell off the diagonal. They were all along the diagonal, no outliers. So in terms of moderators, we did these meta-regression analyses where we looked at design and characteristics of measurement artifacts, study quality, raters, and so on, sample characteristics, age, percent female, GAF scores. We were limited in some of the characteristics we could look at because not enough studies may have had measures that cut across the various characteristics. And we looked at treatment characteristics, orientation, PDT for psychodynamics, CBT for cognitive behavioral, DBT versus non-DBT studies. We looked at intensity in terms of the number of hours per week, length, weeks, total attention, as well as individual versus group, inpatient versus outpatient, et cetera. I'm going to turn to results. You guys may be waiting for it, much like that lady. In terms of our sample, the mean age was 31, mainly women in the studies. We had 32 controlled studies, as I mentioned earlier, 10 psychodynamic, 22 cognitive behavioral, 7 RCTs of psychodynamic treatment, 19 RCTs of CBT, 14 dialectical behavior therapy reports. The pre-post analyses included 17 psychodynamic treatments and 44 cognitive behavioral. We rated the quality of the studies. The mean quality was 15.3, a little bit low given the range, but the RCT qualities were higher. We wanted to be able to look at quality as a moderator. In terms of what we found with the within-group effect size, we actually found an effect size, Hedges-G, of 0.828. And the confidence interval you can see is actually quite nice and tight. But effect sizes are, I find effect sizes, understand what an effect size means, or it's like trying to understand what a heritability index means. The numbers seem to make sense, but they're actually hard to interpret. And so I thought I would actually try to unpack this a little bit and try to explain to you what it actually means that the effect size is 0.828. And so what you do with the effect size is you actually look it up on a normal curve to see where the percentile falls. And what you find if you do that with an effect size of 0.82 is that if the average patient being treated at post-treatment, the average treated patient is doing better than 80% of patients entering a treatment. And so that's actually considered a large effect size and is actually the good outcome that we found. The rest of it could probably be characterized as the good, the bad, and the ugly. But in terms of pre-post effect sizes, that's actually a nice effect size where you can think that 80% of your patients at the end of, the average patient will be doing better than 80% of patients that would be entering the treatment. Now, in terms of the between group effect size, it was much smaller. It was 0.23, and that's actually considered a small effect size. You can see the confidence interval is not quite as tight, but what's really important here is it doesn't go below 0, so it's a reliable finding, and the effect size range is still all within the small effect. Let's see. In terms of trying to explain what that means, there's a couple of ways we could do it. The way I described the within group effect size, it turns out that this effect size corresponds to the 58th percentile, which means that the average patient in the experimental condition, the psychotherapy condition, is doing better than 58% of the patients in the control, which is not all that great. To put it into another statistic that might be more easily understandable is, you might see here the number needed to treat is 9. That's also considered a small effect. What that essentially means is that you need to treat 9 patients before in your experimental treatment, whether it be DBT, TFP, schema-focused therapy, MBT, before you're going to see one patient that does better than the patient in the control group. If you look at a lot of the psychotherapy studies, what you find is that they have sample sizes of about 20 or 30 people in it. What you're talking about is essentially differences between groups that are probably a function of 2 or 3 patients actually doing better in the experimental group than in the comparison group. So there it doesn't look so good, but there's more to the story. Oh, this didn't show up nearly as well as I would like. Okay, this is a funnel plot. And what we did with, in using this funnel plot was to actually look and see if there's any publication bias that might be affecting the effect sizes. And it turns out that there is. You can see that there are studies that aren't represented here, where these would be low-end studies that also have low effect sizes. Most likely, these studies can't get published. Okay. Most likely, those studies can't get published. Okay. And this trim and fill plot sort of shows us where those studies would actually be. Let me talk a little bit about the moderators, because that's actually where I think a lot of the important findings are. We found that the year of the publication actually, as an artifactual moderator, actually affected the effect size, as well as using dichotomous variables as opposed to dimensional variables, and the study quality too. So interestingly, the higher the study quality, the lower the effect size. And this is actually not a finding that's inconsistent with other disciplines. We also looked at control group. It turns out that if you used a waitlist control group, you had a higher effect size than if you used a TAU control group. There were a handful of studies that did use waitlist controls. The majority did use TAU groups. We also found that component controls actually had smaller effect sizes than TAUs. There were only a handful of studies that used component controls. And then there was no differences between TAU versus a empirically supported treatment or a active treatment that wasn't yet empirically supported. And that's probably because there was a lot of variation within these groups. In terms of outcome measurements, having blind raters resulted in better outcome than self-report ratings, so we got stronger findings when we were using observer raters. You got even more stronger ratings if you use non-blind observer raters, and completer analyses provided stronger ratings than ITT analyses. Actually, there's a finding that I think is left off this slide, which is actually that for measures that looked at personality variables, there were smaller effect sizes than for symptom measures, and this relates to Joel's talk, which there are lots of studies that show that with between 4 and 6 months, you see a lot of symptom reduction, but that personality change, if one was interested in it, doesn't come nearly as quickly. Age also, the younger the patient, the worse the outcome. The older the patient, the worse the outcome. And in terms of treatment, and this is important, there were no differences between psychodynamic treatments and cognitive behavioral treatments, both in between and within groups, although there was a trend within groups favoring actually psychodynamic treatment. We'll talk a little bit about that. And in terms of looking at non-DBT versus DBT treatments, no differences. Again, there was actually a trend for within-group effects favoring non-DBT. No differences in terms of contact length intensity. And let me sort of address both those trend findings. When we sort of explored that more, what we found is that there's a lot of DBT studies that have been coming out in the last few years that look like they're using convenience samples that are available to people. In fact, 4 out of our 5 dissertations that were included were of DBT studies, and they had, and these studies had lower effects, which pushed it in this direction. We don't really think that DBT has lower effects. No differences in terms of modalities and settings. We did a final meta-regression analysis and essentially confirmed the findings with regard to control group with the within-group analyses, as well, with regard to observer raters with the within-group analyses, and also with completer status and with the between-group effects confirmed the findings with regard to control group status and study quality. Okay, I know that that's a lot. This is actually showing your publication related to study quality. It's getting better. Our study quality is getting better over time, but unfortunately, as the quality gets better, our effect sizes are getting lower, and this shows you, you can see sort of the scatter that there's really no difference between dynamic and cognitive behavioral in terms of study quality there. Okay, 2 minutes. I think I can do this in 2 minutes. Okay, so quick summary. The within-group effect sizes were large. The between-group effect size, which are more important, were actually small. No differences between CBT and psychodynamic treatments in both those within and between-group effect sizes. No differences in the quality between CBT and psychodynamic treatments. Study quality correlated with publication year. Study quality correlated negatively with effect size. And there seems to be a publication bias where small n studies with small effect sizes are not being published and therefore inflating the effect size, so that 0.23 is actually could be lower if those studies were actually out there. We had moderators, which is important, but our moderators, other than age, tended to be all design-related issues. So what we're finding is that actually what's influencing the outcome doesn't have to do with the issues around treatment or issues around patient characteristics minus age, but actually has to do with how you actually design your study. And now we know a lot more about what kind of studies we might want to show. But the important point here is that there's no evidence of the superiority of any one treatment over the others. And this is important because this means that there are more treatments available to clinicians to use when they are actually confronted with a patient with borderline personality disorder. And let's face it, people come out of TFP or schema focus or MBT or DBT having failed those treatments, and now they have options. And I'm seeing Mary standing. I'm going to suggest, I guess I may be out of time. I'll stop here. And hopefully, if people have questions, I can get to some of the other points I might have wanted to make if there's time.